All right, and we are recording. So I am so pleased tonight to introduce Dr. Yasmin Zerhouni. She is a colorectal surgeon devoted to helping patients by applying the latest medical advances to deliver the highest quality of care at City of Hope. Dr. Zerhouni pursued medical training at Johns Hopkins University. Oh, I'm going to just remind everybody to mute themselves, please. Thank you so much. Dr. Zerhouni pursued medical training at Johns Hopkins University, after which she served as a resident in general surgery at the University of California, San Francisco East Bay, and a fellow in colon and rectal surgery at the Cleveland Clinic in Florida. She was also a research fellow at Brigham and Women's Hospital in Boston, conducting studies aimed at expanding access to surgical care. While a medical student, she studied tuberculosis in South Africa. The American Society of Colon and Rectal Surgeons invited Dr. Zerhouni to give a podium presentation on her research on the effects of the Affordable Care Act on colorectal cancer screening at its 2018 annual scientific meeting. Before coming to City of Hope, she was a member of the clinical faculty at Ross University School of Medicine in Florida and at Kaiser Permanente, Northern California in Oakland. So with that, I will hand it over to you, Dr. Zerhouni.
Thank you so much for that kind introduction. Nice to see everybody this evening. Thank you for participating in this discussion tonight. The topic is just talking about colorectal cancer screening. This is Colorectal Cancer Awareness Month, and really screening is the first step for controlling the incidence of colorectal cancer out there in the world. Obviously, we are ready and willing to treat patients once they're diagnosed with the cancer, but we would love it if you never got cancer in the first place, and that's what screening is trying to help us do. I have no financial disclosures. So this is just sort of an outline of what we're going to talk about briefly. So in the introduction, you heard a lot of this information. I'm originally from Baltimore. I went to Johns Hopkins for medical school, and then I just moved here to Southern California from Oakland. So what is a colon and rectal surgeon? So we are surgeons who treat diseases of the colon, rectum, and anus. Those are diseases such as colon cancer, obviously, rectal cancer, anal cancer, but also diseases like Crohn's disease, ulcerative colitis, diverticulitis, hemorrhoids, anal fistulas, and fissures. We often use minimally invasive techniques like laparoscopic surgery and robotic surgery to treat our patients. And obviously, if you are a colon and rectal surgeon, you can't take yourself too seriously because you get to make all the good poop jokes. So, I don't know if we can do this virtually, but by show of hands, does anyone here know someone with colon or rectal cancer, or maybe even has been a colon and rectal cancer patient themselves? And I'm sorry, I'm not the best at Zoom, so may not see the raised hands. So I might ask for Rachel's help.
I see some hands, as well as, some people's videos are off, but you're welcome to type yes into the chat if you know somebody with colon cancer.
Okay, thank you so much. So colon cancer is very common. It's the in the United States, after lung cancer, it's the second most common cancer in men and women. And just by way of example, I thought we could play something sort of Hollywood Squares. So this is an actor named Ryan Reynolds. He's 45 years old, which happens to be the new age at which we recommend that people start their colon cancer screening. And basically on a bet with a friend of his, he lost the bet. And if he lost the bet, he needed to get his colonoscopy done on TV, basically, and he did, and it went wonderfully, and they found a polyp and they completely removed it, which means that that polyp cannot turn into a cancer in the future. This is someone else quite well known with colon cancer. This is Charles Schulz, the creator of the Peanuts comics. And unfortunately, at age 77, he was diagnosed with metastatic colon cancer, which means colon cancer that has spread to other organs in the body, and he died within a few months of his diagnosis. So it's kind of two extremes of the disease process. This is not Hollywood, but she's very well known. Supreme Court Justice Ruth Bader Ginsburg. She was diagnosed with colon cancer at age 66. She was treated with chemotherapy, which was successful because ultimately in the end, she died of pancreatic cancer, not her colon cancer. Sort of staying in Washington, but coming back to Hollywood, this is former President Ronald Reagan. At age 74, while he was president, he was found to have a cancer in his right colon, and it was treated with surgery. And, ultimately lived 20 years longer, passed away from pneumonia and Alzheimer's disease and not his colon cancer. This is Eartha Kitt. She passed away when she was 81. And she is someone who was diagnosed with stage 3 colon cancer. That means colon cancer that has spread to the lymph nodes, but not to other organs. She had surgery for that. And unfortunately, and I don't know how many years afterwards, even after her surgery, the cancer came back, had spread to her liver, and she passed away on Christmas Day in 2008. And then at the other end of the age spectrum, here is Chadwick Boseman, another young actor who's diagnosed at age 40. He was treated with surgery and chemotherapy, but the cancer returned and it had spread to his liver, and he died of the disease at age 43, which is quite young for colon cancer. So I know many of you raised your hands to say that you know people, or maybe you are people who have colon cancer, but this is just sort of an example of how prevalent it is, but also sort of how different the disease might be. It can be everything from a precancerous lesion to a polyp in a polyp, or it can be cancer that has spread to many organs, and that's really what will be life-threatening for patients. So we would love to meet patients before any of that happens, which is why we put an emphasis on colorectal cancer screening. So what is colon and rectal cancer? It's when the cells lining the colon develop mutations over time that lead to cancer. So when we talk about polyps in the colon, those are precancerous lesions that during a colonoscopy we can remove so that they can never turn into a cancer. And we usually say it takes 10 years for a cancer to grow to 1 cubic centimeter. And so if we find the polyps, before they've gotten big at all, we're likely to prevent them from turning into a cancer. Colorectal cancer can usually spread to the lymph nodes, the liver, and the lungs. And the usual treatments for it are surgery, that's the mainstay, chemotherapy, and radiation. So what are the signs and symptoms of colon and rectal cancer? For many patients, what they'll notice is blood in their stool all of a sudden. And, they might think that it's hemorrhoids, and they treat their hemorrhoids and the blood continues, and that should lead to a degree of suspicion for something else that's going on. There can be a change in the caliber of the stool. Patients will frequently say, I used to have sort of normal sized stool and now they look like little thin pencils. That is concerning because as the cancer grows, it narrows the colon. And so then when the stool comes out, it becomes very narrow as well. Changes in your bowel habits are also concerning, and unexplained, unintentional weight loss are also some symptoms that would be concerning and should be worked up.
Someone did have a question just
Sure.
about metastatic cancer. They asked, if the cancer is metastatic, how can you tell what the main cancer is or the origin of the cancer?
That's an excellent question. And even I rely on, in surgery, we work as a team with doctors of different training. And one group of doctors who I rely on immensely are pathologists. Pathologist is a type of doctor who is trained to look at tissue under the microscope, and they have a variety of different techniques in order to see. So say somebody is found to have a mass in their liver, And, it's not liver cancer, and it's not something that's inherent to the liver, but they don't really know where it's come from. They do a biopsy, and in the laboratory, they do different studies to see different tissues in our body express different proteins. And so their different stains will try to pick up, the different proteins that the different tissue makes. So skin cancer, for example, is more likely to produce one type of protein, whereas colon cancer produces a different type of protein, and the pathologists have different stains to help us figure it out, which is extremely helpful. They are some of the smartest doctors at the hospital, and they're very, I really enjoy talking to them because they really help me understand my patients' diseases and what they're going through in a way that I can't do by myself. So that's one aspect of surgery that is great, because it's truly a team sport. So there are also, we just know from different cancers what the pattern of spread is. So colon and rectal cancer has a tendency to spread to the liver. Breast cancer, in contrast, tends to spread to the bone. Lung cancer likes to travel to the adrenal glands, and so we kind of have to put the whole picture together, and also have good pattern detection to figure out where distant cancers are coming from. So what are some risk factors for colon and rectal cancer? Unfortunately, the American diet is kind of a risk factor for colon and rectal cancer. Diets that are high in fats, and animal fats in particular, and diets that are low in fiber. You're also at a little bit of a higher risk if you have a sedentary lifestyle. Colon and rectal cancer is also associated with obesity. There is a genetic component to colon and rectal cancer. There are certain really well-known conditions associated with a higher risk of developing colorectal cancer. And then, we just find certain families where, a person will develop colorectal cancer earlier than is expected, and that makes us suspicious for a genetic source or genetic cause for their cancer. And then a personal history of certain conditions, such as inflammatory bowel diseases like Crohn's disease or ulcerative colitis, can also put you at risk for colorectal cancer. And then certain groups are at higher risk than others. So African Americans are at higher risk for colorectal cancer. And for a long time, we've recommended that they start screening at an earlier age than other populations, as well as Ashkenazi Jews. So what can you do to reduce your risk of colorectal cancer? Be physically active, avoid excess weight. That's easier said than done, I know, but definitely you should try. And then really the biggest recommendation that I can make is increasing the fiber in your diet. So we know that countries that have high fiber diets have less colorectal cancer than the United States does. Fiber comes from things like vegetables, fruits, beans, whole grains, nuts. If you look on packaged food on the side, they always list what the dietary fiber content is of the food. And the average American only gets about 16 grams of fiber a day, whereas the recommendation is that women get 25 grams of fiber a day and men get 30 to 35 grams of fiber a day. So the solution is to eat a plant-forward diet, when we're thinking about what we're eating on a daily basis, really making plant-based products the foundation of what we're eating, and minimizing eating red meat in particular, and other animal fats. And then even I will tell you that it is hard to eat 25 grams of fiber a day from just your diet. Fibrous foods is the kind of stuff that takes a while to eat. Certainly, I'm not living that kind of lifestyle where I can have a sit-down meal at every meal. And so using a psyllium-based fiber supplement, such as the things made by Metamucil, but you can find a generic of it, is an easy way to make sure that you boost your fiber intake for the day. And the benefits of the fiber is that it will keep the colon healthy. The fiber is what the bacteria in your colon like to eat, and they break it down into a molecule that your colon cells like to eat, and that keeps your colon cells happy. And if they're happy, they're less likely to start to develop mutations that will lead to cancers. Fiber also helps with bowel habits. If you're somebody who has constipation or even with diarrhea, it can help with that. It helps reduce the bad cholesterol if that is an issue for you, and that makes your heart healthier, and it helps control blood sugar as well if you have any issues with glucose control or diabetes. Okay, so who gets colon cancer? As I was saying before, breast and prostate cancer are very common as well, but amongst both men and women, the highest cancers are lung cancer and then colorectal cancer. And then over here in the column all the way on the right, the question is not only who will get the cancer, but who is going to die from the cancer too. So with lung cancer, unfortunately, it's almost a 2-to-1 ratio of people who are diagnosed with lung cancer who ultimately die of their disease. And this is because we don't have good screening modalities for lung cancer. And by the time we find out that someone has the disease, it's usually too advanced for us to help them. In colon cancer, it's about a 3-to-1 ratio. And by point of comparison, if you look at breast cancer and prostate cancer, it's like a 7-to-1 ratio. So while those cancers are more prevalent, death from them is not as likely as it is from lung and colorectal cancer. And then looking at both by sex and by race and ethnicity, men are higher risk of getting colorectal cancer than women. And then, as I was saying, African Americans are at higher risk, in particular African American men, also non-Hispanic American and India, Alaska Natives are high risk populations. And so, if we know that a population is at risk, we really should be emphasizing screening for them to minimize the likelihood that they'll get a cancer. This is just showing you sort of how old people are when they get colon or rectal cancer. In most patients, it's in their 60s to their 70s, which is why we used to recommend to start screening at age 50. Unfortunately, this graph has been shifting to the left, meaning we're seeing more and more younger patients with colon and rectal cancer, and we don't really understand why. But in order to address that, we've decreased the screening age to age 45 with the hopes of discovering people when they have just precancerous lesions, or if they do have a cancer at a younger age, that we find it at an earlier stage before it can spread and cause real harm to their life. And so, if we find your colorectal cancer when you're younger, you're more likely to survive, right? As we get older, we develop other conditions that are harmful to our health. So when patients are diagnosed with colorectal cancer, the median age at death is 72. So 5-year relative survival is kind of our gold standard for any cancer. And so this is sort of saying after someone's been diagnosed with colorectal cancer, how likely are they to survive 5 years after their diagnosis? So localized cancer is what we would call an early stage cancer. It's still only located in the colon and the rectum. It has not spread to the lymph nodes or anywhere else. And if we can discover it at that point, the likelihood of 5-year survival is 91%. If the colon or rectal cancer has spread to the lymph nodes, the likelihood of survival is 73%, right? And distant disease means metastatic disease. We always like to use multiple words to say the same thing in medicine to confuse our patients as much as possible. So distant equals metastatic. And unfortunately, as you can see, if the disease is distant or metastatic, the survival rate is really low. And that's why we really need to emphasize discovering the disease at an early stage, because that's when we can be most helpful. So who should get screened for colorectal cancer? So screening tests any screening test needs to be reasonably priced so that everybody can participate in it. It needs to demonstrate an ability to find the disease of concern, or it's able to target the at-risk population. And, it cannot be too expensive. If we're saying everybody should get a colorectal cancer screening, it can't be more than the cost of treating the disease. So the goal is to identify patients at an early stage of their disease so that we can give them as many quality years of life as possible. And ideally, we prevent the disease. And so certain patients with certain chronic or genetic diseases, we might recommend that they start screening earlier because their risk of developing disease is higher than someone else in the average risk population. So what kind of tests are out there? I feel like many people know about a colonoscopy, but they don't realize that there are less invasive tests out there. And for some patients, especially these last couple of years during COVID, I'm meeting a lot of patients who find out that they have a colon cancer and they avoided going to the doctor during the pandemic because they were so afraid of COVID. And in the meantime, they actually had a cancer that needed to be addressed, but they didn't get their colonoscopy on time. So, if you have concerns like that, you don't want to get an invasive procedure like a colonoscopy, or you're afraid of having too many interactions with the medical community right now because of COVID or other reasons, there are other ways of getting screening, which are stool tests. On the one hand, these tests are great because you can usually do them at home. On the other hand, if the test comes back positive, we recommend that you get a colonoscopy done in order to figure out why is it positive. And then for it to be most helpful, most of them need to be done more frequently than a colonoscopy. So the first one is a fecal occult blood test. This is just looking for blood in the stool. You don't have to do anything special. You take a sample of your stool at home and you mail it in. And then again, you need to do it every year. If it's positive, you're going to need a colonoscopy. Another test is a fecal immunochemical test, what we call a FIT test. It tests for blood in the stool using antibodies. So this is very similar to kind of the technology in your at-home COVID test, using antibodies to pick up on the blood. And it's much more sensitive, meaning it picks up more positive cases than the fecal occult blood test. Again, it needs to be done annually. You can do it at home. It's not expensive, but if it's positive, we need to do a colonoscopy. And the last one is what many people know as Cologuard, and that's a stool DNA test. So that's taking it to the next level. So this would be more similar to like the COVID PCR test that you might have had done in order to confirm a COVID infection. So this is taking the sample of the stool and checking it for any blood and checking it for any abnormal DNA that might have come from a tumor and tumor cells. And this one can be done every 3 years. You don't need a preparation. The problem is it's fairly new, and so it's more expensive, and insurance companies are not always covering it. And again, if it's positive, you will need a colonoscopy. So colonoscopies, I've said the word so many times, so let me define it. A colonoscopy is a procedure. You need to have sedation in order to get it done. That means that the day before you're not eating anything after midnight. We also ask you to completely clean out the colon before we do that. And a lot of people, they find that really uncomfortable. We use a long camera to look in the rectum and the colon, and we're looking for polyps, or if we find a mass, we'll take biopsies of the mass. And if we find polyps, we'll remove them. So the reason why we like colonoscopy is it's not only is it diagnostic as a screening modality, but it's also therapeutic. We can remove precancerous lesions during a colonoscopy. Some patients really like it because they kind of want to do what's called concentrate the pain. You get your colonoscopy done, and if we don't find anything, you can repeat it in 10 years. And then, if we do find something, the recommendations change a little bit. On the downside, it's expensive, right? Not so expensive that it's not a good screening modality. It is a good screening modality, but compared to the at-home tests. And so another modality is a flexible sigmoidoscopy, very similar to a colonoscopy, but this can be done in the office without sedation. It needs to be done every 5 years with a stool test. And we can remove polyps. The issue is that we only can look at the left side of the colon with a sigmoidoscopy. It doesn't go all the way around. And then the last one is a virtual colonoscopy. This is, you need to do the preparation just like you would for a colonoscopy. And it's a very, basically an advanced CT scan. They use a little bit of air, put air into the colon, and then they do a CT scan to look for any polyps or masses in the colon or rectum. And so this we usually reserve for a patient who, for whatever reason, we haven't been able to do a colonoscopy. I had a patient where the FIT test was positive more than once. Colonoscopy was attempted multiple times. And so our solution was to do a virtual colonoscopy in order to really find out why were her FIT tests still positive. And turned out she had 2 big polyps. And that's why. Any questions about those screening tests? Okay. So I just talked about a bunch of different screening tests and sort of what is the right test for you. The right test for you is the one that you actually get done. There's no virtue in one type of test or over another. We would rather find out about your cancer sooner rather than later. And so I would just encourage you, if you haven't done it yet and you are of the right age group to be screened, you should get it done, whichever one sounds sort of the best to you. For some patients, that's the stool test, and for other patients, it's the colonoscopy. So the other thing, and this is sort of my area of research, is what resources are available in your community. A colonoscopy needs to be done by a trained professional, such as a gastroenterologist or a colorectal surgeon. And not every community has that available. Here in this part of Southern California, we're lucky, we kind of have a bunch of different doctors and hospitals available, but in a lot of other places they don't. And for those places, a stool test might be more reasonable. And then the other thing is that you have to be willing to keep up with your testing as well. So when should you start screening? Again, like I said earlier, the new recommendation is to start screening at age 45, or if there's someone in your family who had colon or rectal cancer, you should start screening 10 years before that person got their diagnosis. If it was less than, like, for example, if it was somebody in your family who was 50 years old, you should start when you're 40. And this is because of this data of seeing an increase in colorectal cancer in younger people. And then this is kind of controversial. When should you stop screening, right? So screening tests are there to help prevent cancers. And we know that cancers tend to happen as we live longer. But they're not all screening tests are entirely benign. Colonoscopy, for example, is a procedure that has risks. And so usually you should have a conversation with your doctor, right? If we are removing precancerous lesions and we know it takes 10 years for those precancerous lesions to turn into a cancer, if your life expectancy is not that long, should you put yourself at the risk of getting the screening test? So for some patients, they've had this conversation with their doctors and it's kind of offensive to them. And then I have patients who are well over the age of 75 who I expect them to live a good number of years, beyond that. Who do have concerning findings on their colonoscopy. And those are patients that I would happily operate on. So it's a hard discussion to have, but it's also something to take into consideration. So, like I said, we know that as we age or as we're exposed to different risks, we're at risk for different cancers, and there are a variety of different screening tests that should be done. So, for example, For women, mammography for breast cancer and pap smear for cervical cancer. For men, a PSA blood test for prostate cancer. There was really an excellent study that came out in 2012 that looked at using a low dose CT scan for people with a long smoking history. And that actually for lung cancer, like I showed you before, which has a very unfortunate prognosis, for lung cancer has actually made a big difference for that at-risk population. So that's a screening test that's working because it's really identified the population that will benefit the most from it. Here in Southern California, with all the sun that we get exposed to, except for not this winter with all the atmospheric rivers, you should think about skin exams for skin cancer, such as squamous cell carcinoma, basal cell carcinoma, or melanoma. And then you should also think about screening tests that are based on your family history. If there are cancers that run in your family, you should be sort of more aware than other people might be of being at risk of having that cancer. And with that, that's what I have to say about colorectal cancer screening, and I'd be happy to take any questions.
Ready to talk? Ask her something.
Thank you so much, Dr. Zerhouni. Sorry, I'm starting my video and audio here.